beginning an outline and try to highlight which part we're on in the outline. And so the 3 topics are depression, dementia, and delirium, but within the depression part, we'll talk about the diagnosis, then we'll spend some time on differential, and then the different treatment options. And keep in mind that I'm in the family practice setting, and other people may have a different perspective, but I'm giving you kind of my perspective on it. Then we'll move into delirium and finally into dementia. So for the prevalence of major depressive disorder, it's a pretty high prevalence when you think about it. About 1 in 5 or 20% of women have depression at some point in their life. About 12% of men, so it is a higher frequency in women. And it's the 4th most common presenting complaint in the setting that I work. And I'm telling you that I see a ton of it. In the practice that I'm in, I actually enjoy seeing depression and anxiety. I view it as kind of an honor when patients are open with me and talk to me about some of those things. Some other providers may not really enjoy that disease and that diagnosis. And so the women up front who schedule the appointments, or the men, whoever it may be, know that I enjoy it, and so they'll kind of funnel those patients to me. And you'll find that different practices may do that, depending on what you may or may not like when you get out. But so I really do see a lot. In fact, yesterday morning, I think I'd seen one, and I was like, this is crazy, I've only seen one. But never fear, the afternoon still came. Made it work. So, get more. All right, so here's your criteria from the DSM-5 book. And there's an easy way to screen. Patients have to have those 2, either depressed mood or a decreased interest or pleasure. If they don't have either of those, then you can just kind of move on. But if they do have one of those, then you kind of need to do some more further questioning. And that's those other things: fatigue, feelings of worthlessness or guilt, decreased concentration, weight gain, or loss. It doesn't have to be gain. The feeling of, not the feeling, but the actual sluggishness. It can't be a self-perceived sluggishness. It has to be something that's perceivable by other people. And then the thoughts of suicide. Also, they need to be all concurrent during the same 2-week period. So you can't have them at different times. Okay. They do need to cause significant impairment in the patient's function. So it can't be on such a minimal level that they're not really hurting the patient in some way. So, in addition, you don't want them to be due to something other than depression. You want them to be, you don't want it to be a thyroid problem or a medication problem or maybe alcoholism. If you start an antidepressant, you're not really going to help them. Okay, risk factors for depression. Older patients have a much higher incidence of depression. We'll get into that a little bit. Alzheimer's disease, 40% of those patients have depression, so that's something to keep in mind. Recent childbirth, recent stressful events. I often will ask patients about their family history of depression, not even just because they have a higher risk, but also because they will have a perception of their treatment plan. So one time I asked, and the patient said, well, my dad was on Lexapro when he committed suicide, or whatever drug it was. Okay, am I going to suggest that drug? Right. So be sure you ask about that when you're thinking treatment plan, as well as significant diagnoses for the patient. Chronic disease is also significant. So recent stressful events, one thing to think about is patients who come out of, maybe they just got they had a recent MI. I can think of a patient who had a heart cath, and in the heart cath she had, after the heart cath she had a stroke. and was left with some blurry vision in her eye and some weakness in her arm. Well, anytime you have a life event like that, you're going to have these feelings of, I'm suddenly not invincible. Even she was 60s, in her 60s. She didn't think she was invincible, but you suddenly have this realization that death is not so far away. And those patients sometimes will become depressed when they realize that. So sudden illnesses like that, I'll ask the patients afterwards, because I'm the one seeing them in family practice, how you doing? Are you thinking about, are you feeling sad? So those are times to think about depression too. So when we're talking about specifically the elderly, things that will increase depression in those patients, if they're a woman, if they're alone and a woman, that really increases it. If they don't have a supportive social network, so a lot of times I'll ask, do you go to church? Because that's where a lot of women will get their support network from. Stressful life events, we talked about one. Grief, if they've lost a loved one. If they've had a relationship breakup. So those are just some of them. Retirement, that's another one that can be, you think it's going to be fantastic, but frankly, it's so funny because especially, I talk to a lot of women who retire, and if they're married, it's not what it's cracked up to be, because suddenly they're home with that spouse that they love, but maybe it's not all that they thought it would be, spending that much time with their husband that they love. So, just saying. Okay, damage to body image. So, kind of goes back to what I was saying with the, the stroke. Suddenly you can't use your arm like you used to. It's kind of a big deal. It's not actually, it's not just the elderly on that one. So I have psoriatic arthritis, and there was a time for about 2 months where I couldn't use my right hand, and I'm right-handed. That was a really big deal. Fortunately for me, I gained a lot of the use back, but think about those patients, and it's a really big deal where you can easily become depressed when you lose things that you didn't anticipate. Okay, the course of it. Relapsing, remitting. So it can kind of come, be present, get better, treat it, then it can come back. 40% recurrence in the 2 years after their first episode. It's kind of high. So you got to keep that in mind when you're treating the patient, and think about, do you want to take them off? And I do not present to the patients, we're going to do this and get you off this med. I absolutely do not present it that way. Now I'll talk to them and say, let's talk. After you've been on this, if they're doing well on it, let's talk about it. But I don't say, let's get you off this, because that's not necessarily what we're going to do. Especially in the elderly, although one of my goals with the elderly is to get them off as many meds as possible. But after 2 episodes, very high recurrence rate in 5 years. I mean, you can pretty much count on it coming back. So, all right, let's talk more about, specific to the elderly, half of nursing home patients. So who in here plans on being in a nursing home? Right, exactly. So you got to think about that. Nobody does. Nobody wants to be. Depression is the most common cause of weight loss. So if you see a trend of weight loss in the elderly, think of depression. They're not going to come up to you most often and say, I'm sad. They're going to say, I don't feel good, bad, my knee hurts. We have these review of system sheets, and it's ears, respiratory, cardiac. I mean, you guys know the review systems, right? We'll give them to our patients for physicals, and when I see multiple systems, check on those, I know it's depression, like every time. So that's the first place I go with a lot of those patients. But the elderly specifically are not going to say I'm depressed. They're going to have a bunch of somatic complaints. So when you see that, start thinking, could it be depression? They may present with a decline in functioning or confusion. I remember one gentleman came in, probably in his 70s, with his daughter, and she was like, he's just really struggling with his concentration, and he's just kind of confused, and then we mentioned his wife who had died, and I mean, he just started sobbing, and so we started him on an antidepressant, and a few months later, he was so much better. All that confusion and concentration was markedly better. He was functioning well. So keep that in mind. So, and they may deny their depression. He certainly did. So this is, a lot of times it's in, frankly, how you sell it. I mean, that sounds kind of bad, but a lot of times that's what I do when it comes to depression. And it helps them accept that they could be. I think that kind of comes with experience, knowing that they are indeed depressed, but it helps them so much. So they do tend to minimize the severity. No, I'm fine, except for this and this and this, and this and this, and so. And a lot of it, I think, is generational too. The older, tougher farmer. There's a scale called the Geriatric Depression Scale, and you could ask them these 5 questions, and a score greater than 2 would help you know that you need to go a little further with that. Let's see. BDI is what we use in our office, and put it in here for you. So we give the patients this form. It's kind of nice because it gives us a little bit more objective of a measure to see how the patients are doing from visit to visit. And the patients can come back and say, I just don't feel any better. And I can say, the score really shows that you've improved significantly. And so, really? Well, maybe. And it's funny because a lot of times when I tell them their score's better, then they'll kind of start going, oh, well, there is this. So it's kind of nice to have that objective measure of the improvement, as well as just kind of talking to them and fleshing out kind of what it is specifically that they feel better about. So the scales can be nice. All right, let's talk about risk factors for suicide. Being a male, if you're over 55, so again, think about the elderly. I put a couple of statistics in here specific. So they are only 13% of our population, but when it comes to completed suicides, 24%. So that's a very big difference in that rate. So the other part, 80 to 84. Double that of the general population. That's really sad. So really consider the elderly for increased rate of suicide. Okay, comorbid physical illness. So when they have multiple physical problems, well, it's a lot of the elderly again. Social isolation, that is huge. So if they don't have that network of support, and I really do try to, okay, so you don't go to church, maybe you should. You don't have friends, reach out. If they don't want to go to church, what can they do? Look at the library, maybe you can go to the library and find some groups there. Maybe you can go to the YMCA. There are things that everyone can do to find support somewhere. If you get a good relationship with the patients, then they're going to be receptive, usually. So, if they're having the severe melancholic or delusional symptoms, those are pretty significant in terms of considering suicide. Substance abuse or dependence, then you need to really consider, is this someone that you need to, and I guess, let me be clear, what do we care if they're considering suicide? Like if they're coming to my office, what's the significance? Anyone know?
Are the stats higher that they've seen a primary care person recently? I'm saying that wrong, but they've recently seen a primary care physician before the.
Right, so why would these factors, let me tell you, if I see someone, and I absolutely have, I've seen a couple of people come to mind, I'll send them to be admitted. Absolutely, I can think of a 17-year-old boy scared the fire out of me because he was so melancholic, and he was like saying, yeah, I don't care, I'm totally thinking about it. It was scary. And there was one man that I saw, same thing, so isolated, so depressed, an alcoholic, and yeah, those patients, you don't just send on their way with an antidepressant. Those patients need to go and be admitted. Family history of suicide is significant. Command hallucinations, so those are the ones where they're saying, or they're hearing, kill yourself, or get a gun. That's a command hallucination. If they have access to firearms, or they've got them at home, if they're white, or if they have chronic pain, that's significant, especially if it's not treated well. And if they're telling you, yeah, I hurt all the time. And I don't know, you guys probably haven't heard, but I think that's going to go probably up so much, in my opinion, because we've got this new law coming in November 1st, where pain meds are going to be harder for patients to get. So, and then terminal illness, so if they're posted, I guess, ma'am.
What's the process for admitting a patient when they come into your office to get them into like a psych inpatient facility? What do you do after you see them?
So it's really tough. Okay, so in my clinic, we are independent. We're not affiliated with Mercy or Children's or whatever. Mental health is really difficult. What I'll do is, first I have to make sure it's okay with them, that they're cool with it, and fortunately, they were both okay. I'll call around and see if I can get them into like an ER somewhere that will do it, because you can send them, but they're just going to say, don't have anywhere. Yeah. Like with the kiddo, I sent him, even like, I think he was 16, 17, somewhere in there, so he was a kid. And we called around to some of the pediatric, I can't think what they're called, psychiatric single unit things, whatever. Cedar Creek is one of them, I think, and it was one of those places that admitted him. So we have to do the work. It used to be better, like they could just go to Saints or something and that were vets, but it's really rough to find places for those people now. So that's my experience. Okay, differential diagnosis. So if you think about it, it's really kind of anything that can make you feel sad or tired. So Alzheimer's, we kind of talked about 40% of those patients feel depressed. So there's some overlap there, right? Any kind of endocrinologic disorder, there's probably some overlap. So you know that like thyroid disease can make you feel depressed if you're undertreated. Neoplastic lesions of the CNS can cause some psych symptoms if they're not found. So that's up there. Inflammatory conditions. So that's going to be lupus, RA, rheumatoid arthritis, psoriatic arthritis. You guys familiar with any of those? Okay, so that's inflammatory conditions. Sleep apnea. Patients have a really tough time finding those masks that fit, so they're going to feel really, really fatigued because they aren't using their masks. Infectious processes, so they're not, they're fatigued a lot of times. Of course, substance abuse, codependence, other things that we'll cover a few of those. No, I took him out. Sorry, take him back. You didn't hear that. Okay. meds that can cause depressive symptoms. And our poor elderly on so many meds. It's interesting. So I try to take my elderly patients off as many as I can. And I have this one gentleman who, he's probably 72. And this sweet man is so anxious, so anxious. And his medication is where he has focused his anxiety. It makes him feel better. His list, and I'm telling you, he has an extensive list of medications. It is ridiculous. And so I talked to him 4 months ago, and I suggested at that time, yeah, I think about taking me off some of these medications. That like rocked his world. Just the thought of it. And I didn't say we were going to, I just suggested it. And so, that was really tough for him. And so, he's even on, we're gonna get there, an antipsychotic. And he's on, instead of the pill, he's on not a half a pill, he's on a quarter of a pill once a week. It's usually a pill once a day. And so when he came back to see me, I was like, oh, you can do this. We can quit that pill. And he said, I don't know. Got this. He said, no. It's just a crumb. It's just a crumb. I can take it. It's like, it's just a crumb. You can do this. Like, it's just a crumb. That's even better. We'll go over this, but elderly are not supposed to be on antipsychotics, and I certainly didn't put them on. And one of the reasons they're not supposed to be on medications, they're supposed to be on less medications, is because there's so many interactions with medications. And if we can take them off more medications, there's going to be less interactions, less chances of falls. When an elderly person falls, what happens? They break their hip, and then things go down from there. So, and this gentleman's like, stop. So anyway, we're trying. He's going to try to not take that quarter of a pill once a week. So, as well as one other one. So these are all medications that can cause depressive type symptoms. And there are going to be a lot of patients that are on them. Beta blockers cause fatigue in a lot of patients, and but there are compelling indications, meaning there are absolutely reasons that you would put a patient on these medications too. So you kind of have to balance that out in your patients. And so same thing with steroids. You're going to see a lot of elderly on steroids, and it's interesting. You think of your little COPD patients. And they're going to need those steroids to breathe. And there are a lot of drawbacks to using them too. So I had this conversation with a patient just this week. I love my steroids. And they make me feel great because I have inflammation all over. So he and I had he wanted his steroids. And it had been 2 months. And he didn't need the steroids, but he wanted them. And so we talked about all the adverse effects. Until not depression. I'll that in next time. But anyway, so when you get around to it, and you guys think about all of the potential adverse effects, then you can help those patients that really want their medications. And I promise you, we're not even talking about narcotics. I mean, we're talking about medications that can help. You can help those patients get to lower doses of medications that are helpful, but you don't need in very big doses. So, all right, grief. Grief is not just death. Grief can be for a number of different reasons. It can be divorce. It can be a diagnosis of a new illness. It can be getting out of the hospital after an MI. It can be losing a job. Breakup of a relationship. So it can be a bunch of different things. The way that it's described in as normal is if the impact of the event is in keeping with our expected cultural norms. That's clear as mud, right? So it's interesting though. Let's go. Yeah, I'll put this one in here. Okay, persistent complex bereavement disorder. I put this in here to kind of help differentiate the two. I thought it was kind of interesting that they've added this. It is an unusually disabling or prolonged response to bereavement. So I want you to contrast that to what you would consider grieving, okay? So this one's going to include some of the following. Indefinitely yearning for the deceased. A preoccupation with the circumstances of the death. An intense distrust of others. Their sorrow just really isn't ever ending. It just keeps going. Of course, there's depression with it. They want to be with their loved one, and that just doesn't stop. They just want to be with them. It can be 5 years later, and they're still right there in that same place. I can think of two people, and not patients, but two friends who are in this, who have this disorder. So do you guys see the contrast there? I have a gentleman, unfortunately he's not older, but I saw a gentleman, God, it's so sad. He was in his 30s and his daughter was around 7, 8 and was killed abruptly. And it had been a few months since her death. And he came in to see me and he said, I don't want to do anything. I get no joy from nothing. I have an 11-year-old. I mean, I love him, but I just don't want to do anything. I don't get up. I do it because I have to, but I say, I think we passed this. This isn't just grief. I think we're in depression at this point. Let's do some antidepressants. And he really did better. As much as I wanted and tried to get him into some grief counseling, that is not what he was going to do. And I do try to get patients who I think would do better into counseling, but there are some patients that just aren't going to do it. So he was a farmer, and that's not what he was going to do. He was actually a rancher. So anyway, there's some overlap, I guess is my point, with depression and grief, but I think this is a completely different thing that you will see in the elderly. So, depression and anxiety. So there is a lot of overlap in these two. I think anxiety, though, can occur alone. So that's what this slide is pointing out. If the anxiety is only present during depressive episodes, it really doesn't warrant a separate diagnosis. Okay? So it's really nice that the antidepressants that we use treat both. Because I certainly see a lot more of the combined than anxiety alone. Okay, so I also have random videos. This would be the first one. Maybe step into the mouse. So mouse. Where? Right. You're right. Oh, I see it. Okay.
That is one nice ride you got there, kid.
You guys still gonna take me in?
Not yet.
Bold moves. They happen every day.
So that means we're going to the next topic. Or not. Totally didn't say that. Moving to physical findings. So, depression's a really long topic. Okay, so usually in depression, there aren't many physical findings. If it's really severe, I remember this one patient that I had, and the story was so sad. He had been homeless, and he had this horrible story about upbringing, and he came in to see me, and he was pretty kind of homeless looking, but he had like brought himself off the streets, gotten a job, and had this self-esteem, you know, that was down here, and like it was super depressed, very flat affect, you know, and he did so well when we got him on antidepressants, and finally, after some antidepressants, got enough energy and got the mood where he could go to counseling. But he's someone who I would say had such symptoms that he really didn't have the, because he had a job, he had the means to clean up, but he didn't have the energy or the will to clean up. So, but he did much better after that. So that's somebody with the grooming and the hygiene that you would notice. So you may notice some weight gain or loss. You might notice that kind of sluggish. He certainly had that really slow speech, the flattening in the affect. Another patient who's just come in recently, she totally has the pressured speech the first time I saw her. This time I gave her the, I can't think of the name of it, I think it's the PDQ, I think? No. Anyway, gave her the test that checks for bipolar, and yeah, she's totally positive. So, we're going a different route on her meds. So, all right, lab studies. I had someone ask me, can we just do a blood test? No, sorry. I'll check for depression. So, you can check to eliminate other causes, but you can't do a test to check for depression. So that's what all of these do, is you're looking to make sure there's not something else going on. And that's what I do have a lot of women ask for. Let me just see if there's, couldn't it just be my thyroid? All the time. Treatment, really two kinds, therapy versus medication. And with mild to moderate, it's really both are equally effective. So with severe depression, you're really going to find more benefit with the medication than with therapy. All right, so with the medications, you're going to find, and well, that's not true. If it's somebody that I'm kind of worried about, like they're pretty serious, I'll have them back pretty fast, maybe 2 weeks, not counting for the ones who are, I'm admitting, like they're kind of a special thing. But the ones, like the gentleman that was homeless, I had him back pretty fast. I was a little more worried about him. But usually I'll have them back in about 4 weeks, because it typically takes about that long. There's so many misconceptions about medications that patients have. They still think they're going to get addicted to their antidepressants. They still think it's going to make them a different person, that they're going to feel weird, that it's going to change who they are. And so before I start the medication, a lot of times before I even give them this spiel, let me just tell you up front, it's not going to do these things. And then they can start considering if they want to do medication. Because if you eliminate their fears about medication, then they can start, maybe they'll start considering that they might try some. So, let's see. So the statistic is about half show a response. And I will say in my practice, it is higher than that. But that's the official statistic. I do tell patients up front too that, there are bunches of antidepressants, and I do my best to pick the one that I think will work best for you, but it's not always the right one at first. So there are times we'll have to change. So I want to be upfront with them that we may have to change. So if we do, I'm not going, you messed up, or it didn't work, we're done, I'm out. Because if they don't anticipate that, a lot of times that's exactly what they'll do. They'll just give up. So, and I think it's important that you guys catch that bottom. There are no clinical differences in response rates among commonly prescribed antidepressants. Because, well, one, I think drug reps will tell you different. Two, the distinguishing factor between them is going to be their side effects. And frankly, the cost. If you give an elderly patient a medication that costs $200 a month, they're not going to take that. I mean, they're on Medicare, and they don't get medication help. So keep that in mind. All right, so I guess this is kind of my point. Medication selection. So you want to choose your medication based on these factors. Most importantly, provider familiarity. So you need to become familiar with at least a few so that you can tell them the specifics about those medications. There are absolutely, the new medications that are out, I am not that familiar with. I don't use them. Like, why would I give a patient a medication that costs $200? I'm just not going to do it. The reps can be mad at me, I'm okay with that. I'd rather them be mad than my patients. So, but I do tell the patients what to expect in terms of side effects. And I always tell them potential side effects, which may or may not occur. Don't count on it. Because I don't want them to go home and think, oh man, I'm going to have diarrhea now. Because that's not the case either. So, and then I mentioned the patient preference. If their best friend Susie tried Zoloft and had a great experience, that might be the right one to try. I mean, I know it sounds silly because obviously Susie is not related to them, but there absolutely is a component of this that is up here. I don't mean that in a bad way, but there is a component. And if it's appropriate, then it's not a bad choice. All things equal, right? There's no other antidepressant that's going to do better, right? They're all equal. So, anyway. So, medication failure. Medication non-compliance, I'm going to say that's pretty high up there. So, I have a lot that just quit taking it, or they forget it. Inadequate duration of therapy. Well, I took it for a few weeks and didn't work. Okay, maybe I forgot to say that time, you know, if they didn't hear me, or I take it for a month. So, okay, so let's talk about some of the classes. The SSRIs, put all of them up at the top. I use Lexapro a lot. Is it better than any others? Nope, probably not. It's just what I'm most familiar with. It's a generic for it, and I like it. So I use it a lot. It is easy dosing. There's, I know what the doses are. That class has a low toxicity and overdose. This class has a common adverse effect of sexual side effects. Better believe I tell every patient that. Because if they've been having orgasms and they suddenly stop having them, better believe they're going to stop that medication. So, or if they suddenly stop wanting to have sex with their husband, or wife, and we don't want to cause marriage problems. So, and I mean, it's only fair to tell people up front that this could happen because they're not always going to think about it being their medication. And you don't want them coming in months from now saying, I've got this other issue. And you know what it is, but they've been struggling with this now for months. And so, anyway, those are some of the things that you should warn the patients about. Note that Paxil can cause hyponatremia or low sodium in up to 12% of the elderly. And all of these are metabolized by that cytochrome P450 system, so you absolutely can have drug interactions. All right. in this class. Their safety and tolerability is pretty similar to the SSRIs. They do have some additional side effects. Tachycardia. I've seen several patients have to get off of them because of the hypertension, which is kind of a bummer because they'll be doing great from a psychiatric perspective, but then their blood pressure is high, so we'll have to take them off. I had one patient with midriasis. She's like, I work with medical people. Like, I can't have these pupils. Like, that's not okay. I'm so sorry. So they're probably not going to be your first line unless they have maybe fibromyalgia or pain syndrome. You know, maybe that's a good fit for those patients who are depressed and have those. So I do use Cymbalta for those patients. I put down at the bottom about the glaucoma. You don't want to use the Cymbalta or the Savella for patients with those specific types of glaucoma, since you will probably see that. All right, serotonin syndrome. So the SSRIs and the SNRIs are working to increase the serotonin. You do not want to give those in combination with other medications that increase the serotonin. If you do, you have the potential to cause serotonin syndrome. So I put in here some examples of those medications. St. John's wort, triptans, probably not going to see that as much in the elderly. Dextromethorphan, you might, bupropion you might. But some of those symptoms you can see up there, that restlessness, palpitations, rigidity. It can be anywhere from pretty minor, you might miss it, to life-threatening. So there's a big spectrum of how it presents, but of course the treatment's going to be stop the medication that's causing it. So, all right, so then we have these guys, the Vibrid and Brintellix. The only reason I prescribe these is if somebody's side effects are primarily stomach. You do have less sexual side effects than the SSRIs, so that's one of the benefits of spending more money. Now the nifazodone and trazodone, oh wait, okay. Yeah, trazodone, I use actually quite a bit. This is, so trazodone to be used as an antidepressant is kind of a pain. I think it's 3 times a day. I don't really use it as much for that, but I do use it as sleep aid, and I use it a lot. But I don't know, I'm always a little bit hesitant in men because of the priapism. It is certainly not a large percentage, 0.03% of men who have priapism. But for that man that is that percentage, it's a pretty big deal. You guys know what priapism is? Mm-hmm. Okay. So yeah, not cool for that one man who gets it, but for women, certainly not an issue. So I start out at 50, and I think I've gone up to around 50, and I think, I want to say the dosing is like 300 TID or something, so it's a really low dose to use as the sleeping aid, and it works pretty well for patients. Okay. Atypical antidepressants, bupropion and mirtazapine. So, bupropion. So it affects 2 neurotransmitters. Notice serotonin is not on that list, so it's kind of different than any of the others. Anytime I consider this one, I always ask about seizures because it lowers the seizure threshold in patients. I use this one a fair amount. I always think of it as kind of an activating medication. So for those patients who are just really depressed and all the way around, this is a good add-on. Or potentially you can use it alone too. But thus the adverse effect of agitation. So that's one of the, if you think of it kind of activating, but not like a stimulant. You can see how it might be cause agitation or insomnia. So Another indication for it though is smoking cessation. So it's got a couple of diverse indications. Remeron does affect serotonin, but it also affects a couple of others. So Remeron is very sedating. So even if you try to use it as a sleep aid, a lot of times it's too sedating, even for that. They'll have that drowsiness in the morning as well, but it also causes weight gain. So I've seen it used to help patients gain weight as well. Again, that sedation is pretty tough. Buspar. So this is a really different medication than any that we've talked about in the sense that its niche is anxiety. Okay, so this really doesn't help with depression at all. Everything we talked about before has helped with depression. This one, only anxiety. Although, I don't know, maybe it has antidepressant effects that much higher doses, but I don't use it that high. When I use that is for patients who really have a significant amount of anxiety. Those patients who come in, maybe in two cases, they have depression and anxiety, and I've given them an antidepressant, and it's done well for their depression, but they're still anxious. Or the patients who just have anxiety. Either of those two kind of scenarios are where I use this. Now with the elderly, you really kind of would have to be cautious because I think this one would have the potential to cause agitation. And so that would be something to be wary of with it. So, okay, the tricyclics. So there's a lot of these. They're all pretty old. Note they use less commonly. And it's a lot because of the adverse effects. So they have those anticholinergic and antihistaminic effects, sedation, confusion, orthostasis, all of which you do not want in your elderly patients. So really don't want to use these if you can stay away from it. And I mean, honestly, I'm trying to think, the only reason that I use these, I would use metformin maybe for somebody who had bedwetting or, I don't know, I really don't use these much. So, MAOIs, I'm trying to think. I'm thinking like one time maybe I saw these used, and I haven't seen it since. So, I don't think I would use these. Just maybe be aware somewhere that it's a class, and you have that hypertensive crisis risk. So they do have to have a low tyramine diet. But I don't think you guys would ever have any reason to use them. So again, if you're looking for weight gain, you can use that mirtazapine, Remeron if you need to. Probably not so much the amitriptyline. I mentioned the, okay, so enuresis is bedwetting. I bet you that if you're talking about elderly, depending on where they're at, if they're in a nursing home, they're going to find a different option than probably medication. But anxiety, there's quite a few options. Smoking, the bupropion, or maybe Chantix, depending on if they're depressed too. Insomnia, you can use either of those. Okay, St. John's wort, you guys have probably heard a lot about that. In many European countries, it's considered first line. But when they've done studies here, they haven't found that it's efficacious. So we don't have it approved. Bad news about that, about the St. John's wort, is it has many drug interactions. So it is helpful for us to know if your patient's taking it. So that's one of the things I tell patients. You're taking that. Well, the thing is, it really can interact with a lot of medications. So, okay, antipsychotics. So you can use them if a patient's depressed and you've tried a few antidepressants and they're just not where you need them to be. You can use an antipsychotic to add on to help augment the effect. Well, there's Symbyax. that has both the antidepressant and the antipsychotic in one pill. So you can do that for younger patients. You do not want to do that in the elderly. And the reason is, it was actually kind of interesting reading about it. It's like, well, what is it exactly that it does? Oh, it's everything. It's all-cause mortality. So I just put a few there. It can cause pneumonia, it can cause life-threatening arrhythmias, it can cause orthostatic hypotension. So when you go from sitting to standing, they get low blood pressure and fall. It can cause diabetes. I mean, all kinds of different things it can cause, and ultimately die. So that's why we don't give antipsychotics to the elderly. It's interesting, I was talking to my husband about this, and he said that in depressed patients, he will use them. But in nursing homes, they'll get called by the, I don't remember what it's called, whoever comes and audits them. And so then he has to go talk to them about the medications that he's chosen. And he said, as long as he's using it for depression, and the patient who was, just like really tired and not getting out of bed and not doing their exercise is now improved and doing more, functioning well because of it, then they'll be okay. But if you have to prove that. What they really don't want to see is using antipsychotics for patients who are misbehaving. If you have a patient who is yelling and disrupting things, can't use an antipsychotic for that. That's not okay. So that's kind of the difference there. All right. So I do tell my patients at the beginning that we really want to try to set a goal of 6 months minimum, if they're doing well. And then we can kind of talk and see how they're doing at that point. So. If you want to stop one of the medications, here's kind of your general rule of thumb. Reduce the dose by about 25% per week. So discontinuation syndrome is kind of fun. Patients tell you a bunch of different things. They can have these brain zaps where you feel an electric bolt-like sensation in your brain. And it's kind of nice if you learn them that they could, but it's really nice when they come tell you all about how cool they were. Irritability can be a part of that. So, and it's interesting because different patients experience that. Some don't have any problem, and some take a lot longer to taper off their medication. So there's a vast difference, in how patients metabolize different drugs, and it may be longer than a month. So maybe one it took 6 months to get off. So. Yeah, that last point is, I guess, important. The likelihood that a patient will develop discontinuation syndrome is related to the dose and the agent, not how long they've been on the drug. So, okay, so I put these in here, and they're just a couple of different types of therapy that therapists use. Therapy can be really helpful for patients. I think you can talk to the patient and kind of get an idea. It's not useful for all patients, but I'm trying to think. I mentioned the homeless guy. There are life circumstances that can help patients. A lot of my anxious patients. You can go to counseling and they can help you figure out what your trigger is and how to deal with those triggers to help de-escalate, so you aren't doing this every time one of those triggers comes by. Counseling can be really effective, so I do try to get them to go and don't always have success with that. I have one gentleman I talked to who is 50-ish, and he's been struggling at work for a while now. And he's in a situation where his team that he works with is not appreciating him. And at his age, he really doesn't enjoy that. So, and that's how he's gonna end his career. And that's really rough at the end of your professional life. Well, in February, I said, you know, I think it might be good for you to go to counseling. And as with a lot of patients, I knew that. I'll just take a pill. Well, so he told me this week that he got in touch with a counselor. And what it took for him to agree to that was he had his vacation last week. And all of his vacation, he thought about his meeting that's coming up on Monday. He couldn't let it go. So anyway, I'm excited that it's going for him. ECT can be highly effective. When do they do it? When they need a rapid response, when all the drugs have failed, when they've had it before and it worked well. I've never had any part of this, so that's going to be a psych thing. Golly, there's some other therapy that they've started doing, and I politely cannot remember what it is. There's doctors, some kind of IV patients are going and getting. Had some patients going and getting it. I couldn't find it when I left. Anyway, all right, so when do I refer to psych? When I'm not completely sure of the diagnosis, or when there are more severe symptoms that are coming, if I think other treatments might be more helpful. So I can think of one sweet 70-ish-year-old woman. I mean, I had tried so many different medications, and I tried to send her to psych, and she's like, no, I just want to be here with you. And I was like, I don't know what else to do. And we tried, and I just couldn't find anything that would work for her. And she finally agreed to go. So I'm so glad, because I was really at a loss for her. So she agreed, and she went. Against her will. When they really need something more intense, like the inpatient care. So I'll tell you another, a lot of the bipolar patients I'll send when they're out of my comfort zone medication-wise. So I have a few medications that I'll try. I am not comfortable with like initiating Lamictal or lithium. I just don't know those medications that well. So I'll try my few. And if that doesn't work, you have to go to psych. I'm sorry. So, okay, inpatient care. So, when do we do that? When there's a risk to the patient, when there's a risk to somebody else, or when it's sufficiently severe to warrant treatment in a very controlled setting. So these are some of the examples. Let me give you this patient. He was so interesting. I had a 24-year-old gentleman come in, and he sat in my office and just talked the entire time about how he was going to be president, about his job that he loved, that, I don't know, he worked in IT, and he just talked the whole visit. And I'd met him before. He wasn't like that last time I saw him. So do you guys think he warranted inpatient care?
Did he present a threat to anyone else or himself? So no.
I don't think so. He had family. So, yeah, I think that was an abrupt onset. Probably schizophrenia. That was wild. So, I've had a couple of those, and, just so bad for those patients. But, so the prognosis in depression, not 80% can achieve a significant reduction in their symptoms. Oh, we're supposed to take a break. Okay, hang on, we're almost done, I think, with this section. As many as half may not be here, so that. Yep, okay. So you guys wanna take a break?
Yeah.
Okay.